welcome to the deep dive. Today we're tackling temporal arteritis, which you'll also hear called Giant Cell Arteritis, or GCA.
That's right.
And this is really for you if you're revising and need a clear, high-yield understanding of it. We're using some comprehensive revision notes as our guide here.
Exactly. And our mission, if you like, is to pull out the absolute must-know information.
Yeah. Definition, causes, risks, how it works, what else it could be.
Yeah.
The works. Plus, we'll try and give you some memory aids along the way.
Hopefully making it all stick a bit better. We want to cut through all the detail and just focus on what's crucial.
Okay, let's get started then. Definition first. What exactly is temporal arteritis?
So, at its core, temporal arteritis, or GCA, it's a chronic inflammatory disease. It affects medium to large arteries.
And especially the temporal arteries, hence the name.
Precisely. Those arteries on the side of your head. But the key things to grasp are the inflammation, the damage this does to the artery walls, and really importantly, the potential complications.
Right. And you often hear it mentioned alongside PMR, don't you? Polymyalgia rheumatica.
Yes, there's definitely a significant overlap there. They often occur together, though they are distinct conditions. It's also key that GCA tends to target the cranial branches of the aorta, the ones supplying the head.
And it mainly affects older people.
Typically over 55, yes, and it's actually more common in women.
Okay. So on a basic level, what's driving this? What's going on inside the body?
Well, it seems to be an immune-mediated thing. Basically, your immune system, including B cells, starts attacking proteins within the vessel walls.
And this causes damage.
It leads to these inflamed patches, we call them multifocal lesions, along the arteries. They're not usually continuous, and characteristically, you find these giant cells within the inflammation in the artery walls.
The thing that always comes up, the really scary part, is the risk to vision.
Absolutely critical. If the inflammation hits the ophthalmic artery, the one supplying the eye, it can cause permanent blindness. It's why GCA is considered an ophthalmological emergency. If you suspect it, you have to act fast.
That's a stark warning. Maybe a memory tip there. T for temporal, T for time-sensitive vision.
That works. T for time-sensitive. Definitely hammers home the urgency.
So why does this start? What actually triggers this inflammation? The etiology?
Well, the honest answer is we don't know the exact cause. It seems to be a mix of things.
Like genetics?
Yes, there's almost certainly a genetic predisposition making some people more susceptible. And then there's an autoimmune response, the immune system attacking the body's own arteries.
Any environmental triggers, perhaps? Like infections?
That's thought to play a role too, yeah. Things like infections might be the trigger that sets off this faulty immune response in someone who's already genetically predisposed.
And that link with PMR again,
Yeah.
How does that fit into the cause?
It suggests they might share some underlying genetic risk factors, and maybe similar pathogenic pathways, like they're on a spectrum of related conditions.
Interesting. Anything else linked with it? Other risks?
It's worth knowing there seems to be an association with an increased risk of peripheral arterial disease as well. So, affecting limb arteries.
Okay, let's nail down those risk factors then. Who is most likely to get this?
It's quite clear-cut, really. Firstly, age, advanced age, typically over 50.
Right.
Secondly, sex. It's more common in women.
Okay.
And thirdly, that genetic predisposition we mentioned. Certain HLA types seem to increase the risk.
So older, often female, maybe with specific genes. Got it.
Yeah.
Let's dig into the pathophysiology now. What's actually happening to the arteries?
Okay, so the core process is inflammation within the artery walls. It particularly likes the branches of the carotid arteries supplying the head and neck, and of course those temporal arteries.
And the inflammation causes physical changes.
Yes. The walls thicken, the lumen, the blood flows through, narrows, and it can even get completely blocked, occluded.
And the giant cells, what's their deal?
They're a key feature under the microscope. The walls get infiltrated by immune cells, including these very large cells called giant cells. They're probably formed from macrophages fusing together, trying to deal with the damage.
That paints a clear picture. Now, if someone comes in with symptoms suggesting this, what else could it be? The differential diagnoses.
That's crucial, isn't it? Because other things can look similar. You'd think about Takayasu arteritis, another large vessel vasculitis, but usually in younger people.
Okay.
Polyarteritis nodosa, perhaps. Some infections, like syphilis, can cause vessel inflammation. And then, much more commonly, you need to rule out things like migraines as the cause of the headache.
So any new headache or vision change really needs careful thought.
Absolutely. It's not always straightforward initially.
What about the numbers? How common is it? The epidemiology?
Well, here in the UK, the estimates are around 20 to 30 cases per 100,000 people over 50.
And it's more common in certain groups?
Yes, it's definitely more common in people of Northern European descent. It's actually considered one of the more common types of vasculitis affecting those cranial arteries.
And that vision risk again.
That's what makes it such a big deal, particularly in ophthalmology, because prompt aggressive treatment can often prevent blindness. We see it more with increasing age, more in women, more in Northern Europeans.
Is there a specific gene linked?
Yes, the HLA-DRB104 gene is associated with increased risk and also potentially more complications. And again, that link with peripheral arterial disease is part of the bigger picture.
Right. So knowing all that, what are the red flags? What clinical features should make you think GCA?
Okay, so typically you're looking at someone over 60, and the symptoms often come on quite rapidly, maybe over less than a month.
And the classic symptoms are?
Severe headache, often new, usually temporal. Scalp tenderness, hurts to brush their hair maybe. Jaw claudication is a big one.
Pain when chewing.
Exactly, pain or tiredness in the jaw muscles when they chew. And then the visual symptoms, blurred vision, double vision, or even sudden, complete loss of sight.
Scary stuff. Any other signs?
Yeah, you can get constitutional symptoms too, fatigue, losing weight without trying, maybe a fever.
And on examination, what might you find?
You might feel the temporal artery itself is tender, maybe feels thickened or a bit lumpy, nodular. And don't forget about polymyalgia rheumatica symptoms. About half of GCA patients have that aching and morning stiffness in their shoulders and hips.
So PMR symptoms can be a clue too.
Definitely. Other things you might hear about are just general lethargy, low mood, low-grade fever, poor appetite, night sweats. Can be quite systemic.
Okay, could you maybe give us a quick summary? Those key features to watch for in someone over 50.
Let's try that mnemonic. 5 T's, J, V, S, P.
Okay.
Temporal headache, new and bad. Temporal artery tenderness, thickened temporal artery. Teeth, think jaw claudication. Tiredness, those constitutional symptoms.
Got the T's.
Then J for jaw claudication, again, it's really key. V for visual disturbances, any change. S for scalp tenderness. And P for polymyalgia rheumatica features.
5 T's, J, V, S, P. That's helpful. Right, so you suspect it. What tests do you order? Investigations?
Key things are blood tests for inflammation.
Yeah.
And then something to confirm it, usually imaging or a biopsy.
So blood's first.
Yeah, inflammatory markers. ESR, erythrocyte sedimentation rate, is usually high, typically over 50. But, and this is important, it can be less than 30 in maybe 10% of cases. So a normal ESR doesn't rule it out.
Good point. What else?
CRPC reactive protein usually elevated too. You might also see a mild anemia, normocytic, normochromic type, and sometimes high platelets, thrombocytosis.
And autoantibodies?
Usually normal. Routine autoantibodies, complement levels, all typically normal. LFTs, liver function tests might show a raised alkaline phosphatase sometimes.
Okay. And the definitive test, the biopsy.
Correct. Temporal artery biopsy, ideally from the symptomatic side, is still considered the gold standard.
Yeah,
But you have to remember those skip lesions.
Meaning the inflammation is patchy.
Exactly. The bit you biopsy might look normal even if there's inflammation elsewhere in the artery. So a negative biopsy isn't foolproof either.
What about scans? Ultrasound, PT.
They can be useful. Colored duplex ultrasound, if done by an expert, has pretty decent sensitivity and specificity, maybe high 70%. PCT is another option, maybe a bit better specificity.
But you need an expert operator for the ultrasound.
Yes, and it's worth noting that both ultrasound and PTT might be less sensitive if the patient has already started on steroids.
Right. So key points. Normal ESR doesn't exclude it, and the biopsy needs doing urgently, ideally within 2 weeks of starting steroids if you suspect GCA.
Precisely.
Okay, so let's talk management. How do we treat this?
Urgently. That's the main thing. Because of the risk to sight, the absolute cornerstone is starting high-dose glucocorticoid steroids immediately, as soon as you suspect it. Don't wait for the biopsy result if suspicion is high.
High dose like how much?
It depends a bit. If there's no visual loss, maybe something like oral prednisolone 40 milligram daily. If they have jaw claudication, perhaps a bit higher, say 60 milligram daily.
And if vision is affected?
If there's evolving visual loss, that's an emergency. Usually intravenous methylprednisolone first, like a big pulse dose, followed by high-dose oral prednisolone.
And get the eye doctors in.
Absolutely essential. Urgent ophthalmology review for anyone with visual symptoms. The damage can happen fast and be permanent.
What else goes alongside the steroids?
Well, because treatment is usually long-term, you need bone protection. So bisphosphonates are typically given. Low-dose aspirin is sometimes considered, but the evidence isn't super strong for it in GCA itself.
And then you reduce the steroids over time.
Yes, once the symptoms are controlled and the inflammatory markers like ESR and CRP come down, you start tapering the dose gradually, slowly. Maybe 10 milligram steps down to 20 milligrams, then smaller 2.5 milligram steps. It takes months, often years.
What if symptoms flare up during tapering?
You generally have to increase the steroid dose back up to the level that previously controlled it. Relapses are quite common.
And managing steroid side effects is a big part of it, too.
Huge. Long-term steroids have significant toxicity. Osteoporosis is a major one, hence the bisphosphonates, but also diabetes, hypertension, mood changes, muscle weakness. You have to monitor closely.
Are there other drugs used? Steroid-sparing agents?
Yes, particularly if someone's having trouble tapering steroids or is at high risk of side effects. Drugs like methotrexate or, more recently, tocilizumab can be used.
Tocilizumab, how does that work?
It's a monoclonal antibody against the IL-6 receptor. IL-6 is a key inflammatory cytokine in GCA. Tocilizumab can be very effective, allowing much lower steroid doses, sometimes even stopping steroids completely while maintaining remission.
Does that affect the blood tests?
It does. Because it blocks IL-6 signaling, the CRP and ESR might not accurately reflect disease activity anymore, so you rely more on symptoms.
Okay, so summarizing management. Start steroids immediately and at high dose. Monitor CRP ESR, less on tocilizumab. Taper slowly. Protect the bones. Watch for side effects. And always get urgent ophthalmology input for vision problems.
That's a very good summary. Expect a rapid response to steroids usually, but be prepared for a long treatment course and potential relapses.
What's the overall outlook then? The prognosis?
Generally, it's favorable if it's caught and treated early. Most people respond well to the steroids.
But relapses happen.
They do, in up to about half of patients. So long-term management is often needed. The main goal is preventing that irreversible vision loss, which unfortunately still happens in maybe 15–20% of cases, often before treatment starts.
How long does treatment usually last?
Typically 1 to 2 years, but some might need low-dose prednisolone for much longer. Overall survival is generally similar to people without GCA, but there is that increased long-term risk of things like aortic aneurysms.
Right, which brings us to complications. What are the main ones to be aware of?
Vision loss is the big one, as we've said. Permanent blindness from ischemic optic neuropathy. Then there are the large vessel issues, aortic aneurysms, dissections, narrowing of the aorta or its branches.
Any other systems affected?
Rarely you can get central nervous system problems like seizures or strokes. And then layered on top of all that are the potential complications from the long-term steroid treatment itself.
Osteoporosis, diabetes, infections.
Exactly. Muscle weakness, mood changes, high blood pressure, high cholesterol, fluid retention. The list is quite long. It's a balancing act.
So again, early diagnosis and treatment is key not just for the disease, but for minimizing steroid exposure too.
Absolutely. Prompt treatment, careful monitoring, managing steroid side effects.
All right.
It's all crucial for preventing complications and getting the best outcome.
Okay, so to wrap up our deep dive on temporal arteritis, the critical message seems to be recognize it early, treat it fast. Especially in older adults with new headaches or visual symptoms, that immediate action is vital to save sight and prevent other serious problems.
Couldn't agree more. It really highlights how inflammation in seemingly specific arteries can have potentially devastating effects if you don't intervene quickly and appropriately.
A really important condition to understand. If this has helped your vision, do check out pastthemsra.com and also freemsra.com for more resources.
Definitely worth a look.
Thanks for joining us on The Deep Dive.